Welcome to our latest explainer. We're jumping straight into a massive leap forward in medical science today by breaking down the clinical dossier for the REACT Precision Renal Therapy. We aren't just talking about a new pill here or some slight tweak in standard care. No, we are talking about real-time, CT-guided cellular regeneration of native human organs. This is literally precision engineering applied directly to human biology, and it is absolutely fascinating.
To really grasp why this is such a game changer, we have to ground ourselves in the rather grim reality of the current standard of care. Think about it. What actually happens when a patient's eGFR, their estimated glomerular filtration rate, drops below 15? Well, the reality is incredibly stark. The patient enters total renal failure. The only options left on the table are grueling dialysis or just hoping for an organ transplant. Both of those come with severely decreased life expectancy. For decades, the medical community has basically been trapped in this cycle of just managing an inevitable systemic decline.
The primary target of this new Phase 2 clinical protocol is type 2 diabetic kidney disease, which is the single largest demographic facing renal failure today. So what's the mechanism? It's an autologous cellular reinjection. That means they are using the patient's own cells to actively regenerate the kidney's architecture. They're completely abandoning traditional blind surgeries in favor of real-time CT-guided precision. The ultimate goal isn't just symptom management anymore, it's actual structural repair of the organ.
Traditionally, declining kidney function is treated like a downward slope that we just try to slow down until dialysis becomes unavoidable. But the REACT pathway totally flips that script. The whole clinical philosophy shifts toward actively preserving what's known as residual kidney function, or RKF. Even maintaining a tiny fraction of function, like keeping an eGFR of 10 from dropping all the way to 0, can drastically improve a patient's predicted life expectancy. It's the monumental difference between complete systemic collapse and maintaining a functional biological baseline.
Now, to prove this actually works, the trial architecture here is incredibly strict. They aren't treating just anyone. They're hunting for a very specific Goldilocks zone. Patients with an eGFR strictly between 20 and 50, alongside an HbA1c under 10 and stable blood pressure. There's also a delayed treatment group known as Track B. This acts as a standard of care observation window, giving researchers a perfect 12-month baseline of comparative data from blood and urine markers before a single injection even happens.
Let's zoom in on the micro-level biology for a second. Think of the kidney's filtration barrier, the glomerular basement membrane, like an incredibly complex microscopic coffee filter. It's packed with ultra-fine slits that are just 80 to 100 nanometers wide. When diabetes damages this collagen matrix and the surrounding podocyte cells, REACT steps in. Much like neural stem cells in the brain, the highly specialized cells that get injected into the kidney cortex read local chemical signals. They then physically differentiate to repair that very specific damaged filter. It's brilliant. So how do we actually get our hands on these specialized cells? It's through a 100% personalized 3-step autologous loop. It starts with extracting native renal tissue from the patient via a biopsy, processing it in a lab, and then injecting it right back into that very same patient. Because you're essentially recycling the patient's own biological building blocks, the risk of severe immune rejection drops incredibly close to 0, especially when you compare it to using foreign biologics.
Step 1 of this loop is precision extraction. Under real-time imaging guidance, doctors use highly specialized instrumentation to hit a very exact target. The needle has to penetrate exactly 1.5 to 1.8 centimeters deep. Why so precise? Well, any shallower, and they only grab the outer capsule. They have to go deep enough to secure the viable, functional cortex tissue that holds the vital progenitor cells required for the whole process to work.
Step 2 is the laboratory phase, and let me tell you, it is rigorous. After the native tissue undergoes enzymatic digestion, there's a strict 6-week cultivation cycle. They use density gradient centrifugation to isolate only the viable regenerative cells. Once those cells are integrated into a gelatin-based hydrogel matrix, a ticking clock begins. Doctors have a strict, non-negotiable 72-hour clinical administration window to get those living cells back into the patient.
When it's finally time for Step 3, you can basically throw out everything you know about standardized, off-the-shelf drug dosing. This is bespoke biology. Before the reinjection protocol even begins, MRI volumetric analysis determines the patient's exact organ mass baseline. The lab then mathematically formulates a completely unique dose, exactly 3 million targeted cells per gram of kidney mass. It's personalized biological intervention at its absolute peak. But actually delivering those cells safely, that's a massive technical bottleneck. The renal cortex is incredibly fragile, and the target zone is strictly less than 5 millimeters deep. A surgeon's hand literally cannot physically feel a half-centimeter variance deep inside the human body.
It's a total surgical blind spot. Guessing means risking severe structural damage or blowing out the tissue entirely. That's exactly why computational mathematical modeling and continuous CT guidance, using a specialized coaxial needle system, are absolutely mandatory here to hit the exact target.
Once they are inside that tiny target zone, they don't just dump all the cells in at once. They use a really clever pull and inject method. Think of it like evenly seeding a damaged lawn, rather than just dumping the whole bag of seeds in one single spot. Under real-time CT monitoring, the outer needle is slowly retracted, incrementally distributing the calculated cells across multiple microenvironments. This maximizes regenerative signaling across the entire organ without causing a pressure blowout that could destroy the exact fragile tissue they're trying to save.
Obviously, you don't pull off an intervention this precise and just send the patient home to guess if it worked. The longitudinal monitoring is intense. After strict, immediate 24-hour observation, which includes an immediate renal ultrasound specifically looking for procedural complications like a hematoma, patients undergo 24 months of strict efficacy tracking. Continuous eGFR measurements and routine serum creatinine tracking are taken every 3 months to directly map their biological progress against their day zero baseline.
When you pull back and synthesize all of this data, you realize we are looking at a monumental transition in medical science. We've got precise identification through strict diagnostic matrices, autologous regeneration using mathematically calculated cellular volumes, and spatial accuracy that completely eliminates human surgical variance through computational CT guidance. It's a total paradigm shift. We are moving away from blindly managing a systemic failure and moving toward executing highly localized cellular-level architectural repair.
Which really leaves us with one profound question to wrap things up. How will this shift alter the entire future of organ disease? If we can use real-time CT guidance to safely harvest, process, and accurately redeposit a patient's own cells to literally rebuild a kidney's architecture, what other organs are next? The implications of this protocol stretch far beyond just diabetic kidney disease. It challenges us to completely rethink the very limits of the human body. Thanks for joining us for this explainer, and keep questioning what's possible.